who is presenting today about children with prolonged stay in PICU. Dr. Kholoud Al-Mukhaini is a pediatric intensivist in Royal Hospital here in Sultanate of Oman. She finished her fellowship in pediatric critical care from Sydney Children's Network Hospital. She has a major interest in research in NIV and high flow nasal cannula. Dr. Kholoud as well is leading the Pediatric ICU Stimulation Committee under the umbrella of Oman Medical Specialty Board. And today, as usual, Kholoud chose a very interesting topic, and I'm sure we all taking care of one or two child who stayed for a long time in the pediatric ICU. Without any further delay, Kholoud, the platform is for you.
Thank you. Can I share my slides?
Yes, you can, Dr. Please go.
Thank you. Can you see my screen?
Yes, it's okay.
So thank you, Najwa, for the introduction. I would like to thank the organizing committee for inviting us today to present about children with prolonged PICU stay. I have no conflicts of interest. And just a few lines about the Royal Hospital where I'm working. So the Royal Hospital is the referral center for the country for acute and emergency cases. The pediatric ICU in the Royal Hospital consists of medical, surgical ICUs, as well as cardiac ICU, as well as a step-down units, medical as well as cardiac step-down units.
Dr. Kholoud, sorry, the slides are not moving. You are in the preview mode now.
Okay, so I'll stop sharing and try again. Can you see my slides now?
Yes, but if you can maximize it, put it as a slideshow.
Yeah, it's in slideshow.
Can you try it again?
Okay, so I'll stop sharing again. So how about now? Can you see my screen?
We can see your screen, Dr. Kholoud, but the slides are not on slideshow. Just click on the slideshow icon in, there in the toolbar.
Yeah, I'm doing that. Sorry, so I'll stop sharing again. Okay, can I start now?
No slideshow.
Still is not showing, but you can start if you.
Okay.
جربي مرة ثانية slideshow.
Okay, because I'm doing that. Is it better?
No change.
No change. Okay, because I'm trying to maximize it.
خلود, try to go to عرض الشرائح فوق and from there.
It's still the same for you, isn't it?
Yes.
I'm trying to maximize it. So guys, I guess I can't make it work more than that. So is it okay to start now?
Yeah, I think so. You can start. That's fine.
Okay. Sorry. So I was talking about the setup in the Royal Hospital. So the Royal Hospital is the referral center for the country. And the pediatric ICU consists of medical, surgical ICUs, as well as cardiac ICU. Included in that also are the step-down units, are the high dependency units. So we have medical high dependency, as well as cardiac high dependency. The bed capacity is 37 beds in all of these 4 areas. The annual admission is approximately 2,000 cases per year. And the ICU provides all life supports, including high-frequency oscillatory ventilation, nitric oxide, CRRT, and ECMO for cardiac patients. So the unit encourages early mobilization for patients, as well as family engagement. And just like the rest of the other countries, we have been noticing an increase in the pediatric cases with respiratory illnesses post-COVID-19.
Khulud, we don't see all the slide. Can you click on the slide? You're just seeing the second slide only.
Right, so I guess I have to stop sharing again. Okay. So are you able to see my slides now?
I think Khulud, just go out from the slideshow and just click on each slide while you're presenting. That will be better. Now your slides are moving.
Okay. All right. So we were talking about an increase in lower respiratory tract infection in children, which was notable after the COVID-19 pandemic was over. So unlike the previous years, which preceded 2020, before the starting of COVID-19, we used to see seasonal fluctuations and surges in the respiratory illnesses in small children. The situation following the COVID-19 control period has changed for us, and now we are seeing an increase in cases with lower respiratory tract infections, both in small babies as well as in older kids. So in this slide, there is a display of the admissions in the medical high dependency, which is the step-down unit in our setup. And if you can see here that there's an increase in the cases of children with lower respiratory tract infections. So if we compare 2022 to 2021, there is an increase from the previous year. And that, as a consequence, has increased the number of patients who are utilizing respiratory supports in the medical high dependency. So our percentage has gone, so the utilization of non-invasive and high flow in the medical high dependency has gone up to 80 and to 90% as a total percentage of admitted patients. So that highlights the increase in hospitalization and critical care needs, and the increase in pressure on hospital and ICU resources, which leads me to the why we should talk about patients with prolonged ICU stay. So the outline of my presentation is that I'm going to talk about the epidemiology of critical illness development within a population. We'll talk about that children with prolonged stay in the ICU are increasing. We'll talk about the risk factors for prolonged PICU stay, and why should we know about prolonged stayers, and the quality of life in prolonged stayers, and the resource utilization that this group of patients uses. I'll briefly talk about post-PICU syndrome and quality improvement liberation bundles. So why discuss about PICU length of stay? Critical care efficiency and quality are associated with length of stay. So it's very well known that ICUs are major drivers of hospital costs, and that hospital stays involving ICU were times more costly than other hospital stays. The ICU length of stay is an important measure of resource use and economic performance. And bed unavailability results in delay in care or patients being diverted to other facilities with the associated risks of transport and delayed therapies. In addition, there is an improved survival, and there is an increase in children with chronic complexities, and there's an increase in survivors with physical and functional deficits that persist after discharge. Therefore, the focus now for the ICUs is to try to reduce PICU morbidities, and therefore the PICU length of stay. The following paper is describing the epidemiology of critical illness development within a population cohort of children. So in this study, a population of patients, where a population of a cohort of people were followed up for the need of critical care admissions. So in general, critical care admissions was found to be rare in that cohort. The admission rates were highest during the first year of life, as you can see here from the graph, and then started declining steadily. Respiratory problems were among the most common reasons for admission at any age. And after 1 year of life, if you can look at the slide here, patients who presented to the intensive care were more likely to have a pre-existing chronic comorbidities and/or prior ICU stays. So it's very well established in the literature that PICU mortality is decreasing, and that the survivors with moderate to severe disabilities are increasing. This paper comes from Pediatric Critical Care Medicine from Melbourne, and they try to describe the pediatric intensive care admissions and the outcome of intensive care and what happened to the children who were hospitalized in the intensive care over 30 years. So the findings were that the readmissions increased from 11% in the 80s to 31% in the later decade. The PICU stay remained constant. Mortality, on the other hand, in the pediatric intensive care has declined from 11% in the 80s to 4.8% in the later decade. As a result, we are also seeing that the proportion of patients with moderate to severe disability at follow-up has increased from 8.4% to 17.9%. The other thing which was noticed, that children with prolonged PICU stay are increasing, and that there are health-related quality of lives, which was noticed and observed in children with prolonged ICU stay. So this paper tried to look at the long-stay children and the long-term functional outcome and their quality of life over 20 years. So as you can see here from the graph, the long stay admission as a total percentage of ICU has been increasing as well. And the bed occupancy by the long stay patients is increasing as well. So in this paper, they try to look at the outcome of prolonged stay in ICU over 20 years. Similar to the previous literature, the PICU mortality was found to decrease from 6.4% to 3.7%. They found that prolonged stayers were more prone for readmissions to the intensive care, and that every time they present back to the intensive care, they require longer PICU admissions. They found that as a functional outcome for prolonged stayers in the intensive care, around 50% of those patients who stayed long in the intensive care died either during their ICU admission or following their long stay admission. 27%, that is a third of patients, had favorable outcome in terms of being independent for their living. And only 17% had an unfavorable outcome, meaning that they were dependent on others for their daily activities. In this paper, which is another cohort study that evaluated the outcome of patients with prolonged stay, they looked at the percentage of patients who survived with unfavorable functional outcome. So in here, you can see the duration of ICU stay. So you could see here, this is the proportion of patients who stayed in the intensive care more than 28 days. So if you look here in the middle, those who survived with unfavorable outcome were increasing in the group of patients who stayed more than 28 days. In addition to that, so the other papers has also confirmed what is being seen previously, that survivors usually will have will constitute probably around 40 to 50% of the survivors, while around 40% will have an impaired quality scores, and 20% had a poor quality of scores with ongoing health-related issues. So who are the children? Who are children with prolonged PICU stay? How do we define them? So prolonged PICU stay has a variable definition in the literature, and it varied between 3 to 30 days. The most commonly used definitions were the definition that used more than 14 days, and most literature used a stay more than 28 days as a definition for prolonged stay. Obviously, those patients are an important category because they have an associated risks of mortality, disabilities, and increase in resource use. So what are the risk factors for prolonged PICU stay? Combined together, we know that younger children, that is neonates and infants, compared to school-aged children, has more risk to stay longer in the intensive care. The admission diagnosis also matters. So if you have an underlying respiratory dysfunction or a cardiovascular dysfunction or post-cardiopulmonary arrest or post-cardiac surgery, these kinds of admission diagnoses has more risk for a longer stay in the intensive care. The other category is the post-intervention cardiac patients with cardiac arrest prior to admission. Obviously, if you have a higher severity or a higher severity of illness at the time of admission to the intensive care, the chances for prolonged stay increases as well. And lastly, patients who are receiving the most intensive therapies, like patients who are on nitric oxide or high-frequency oscillatory ventilation or renal replacement treatment, were more likely to have a longer stay in the intensive care. As a comparison, patients who were in the cardiac ICU stayed longer than those who were treated in the medical ICU. So why do we need to know about patients with prolonged stay? It's very important to know about those patients because obviously they have associated risk of mortalities and increased risk of disabilities. But they are also an important category because although they are a minority, they tend to use most of ICU resources. So if you look at the graph here, these are of patients who stayed more than 28. In here, you see the duration of ICU stay. So those who stayed more than 28 days contributed to a smaller percentage of the total ICU admissions, yet they consumed the majority of ICU admissions. Similarly, in this example, in the group of patients who stayed more than 20 days, although they were a minority compared to the other subgroups of ICU cases, they contributed or they consumed most of the ICU bed days. So prolonged stayers, although they constituted about 2.4 to 5% of the total percentage of admitted patients, they used about 33% to 40% of the BICU bed days. This is a study that also looked at the consumption of devices in patients who stayed long. So this is the group of prolonged stayers, and this is the group who stayed, who were not prolonged stayers. So in terms of central venous catheter used, the use was higher in the group which has a prolonged stay. In terms of therapeutic interventions, mechanical ventilation was longer in patients who had a prolonged stay, as well as vasoactive drug use, as well as the need for more advanced hemodynamic supports like ECMO. In addition to that, surgical interventions like tracheostomy was more often required in patients with prolonged stay in the intensive care. There's also the complications and outcomes, and patients who stayed longer in the intensive care had higher chances to develop ventilator-associated pneumonias, as well as other hospital-acquired infections. So children with prolonged stay also includes patients with chronic complexities. So who are the children with chronic complexities? So if you look at this slide, this is a classification that tries to look at the definitions of patients with chronic complexities versus those who doesn't have that. So there are three patients categories. The first category is patients who has no chronic disease. An example of that is patients who gets admitted with bronchiolitis or pneumonia when they were previously normal. The second category of patients is non-complex chronic disease. This is a group of patients who have chronic condition like asthma, for instance, which is not progressive, and it could be episodic. The third group is the patients with complex chronic disease. This is defined as either a chronic conditions in 2 or more organ systems, or a progressive condition associated with decrease in life expectancy, or having an underlying malignancy, or being on continuous technology dependence, like patients who are on TBN or who are using oxygen at home or on tracheostomies. So those are patients who are dependent on technology. So in most of the literature, chronic complex patients accounted for about 53% of all BICU admissions, while patients who were previously normal constituted a minority of patients. Chronic complex patients had longer BICU stay, and they have an increased risk of mortality adjusted for their disease severity. So they are also found to, since they are the patients who stays longer in the intensive care, they are also known to utilize ICU resources more. So if you look at this, if you look at this slide here, patients with chronic complex condition constituted a good number of the total patients in the intensive care. Their total central venous catheters use was higher, as well as their need for other support like ECMO and arterial catheters. The ICU cost, as well as the ICU days and mechanical ventilation is higher compared to the group who has non-complex chronic disease or no chronic disease in the intensive care. So increasing medical complexity then is associated with increase in ICU admissions. Respiratory illnesses constituted the most common diagnostic category for those patients when they present to the intensive care. Increasing medical complexity was associated with increased need for procedures, and children with chronic complexity had a greater hospital mortality compared to the other two groups. Therefore, quality projects should focus on patients with prolonged stay in the ICU, because although they are prolonged stayers in general, are less, when we compare patients with prolonged stay, their percentage is less, but they tend to use the ICU resources most. Therefore, it is important for institutions to implement strategies like fast-track care or weaning protocols for ventilated patients, early rehabilitation, management of delirium and withdrawal, and ICU specialization. So patients with prolonged PICU stay has risk factors on admission that predisposes them for long ICU stay, but their stay in PICU could further increase their admission duration and increase chances for physical and cognitive impairment. This is leading me to talk briefly about post-PICU syndrome and PICU liberation bundles. So in 2010, the Society of Critical Care Medicine Conference defined post-ICU syndrome. The definition includes a new or worsening impairment in physical or cognitive or mental health status arising after critical illness and persisting beyond acute care hospitalization. PICU syndrome is linked to negative physical, cognitive, and physiological effects, including acquired weaknesses, sleep disturbances, memory impairment, depression, anxiety, and post-traumatic stress syndrome. The effects of PICU syndrome is not only including patients, but it's also involving the family members. And around 67% of the family members were found to have depression during their ICU admission, as well as a good proportion of them has experienced post-traumatic stress syndrome up to 6 months after their children got discharged. So the PICU focus has then changed from survival and improved resuscitation to preventing post-PICU syndrome. Therefore, quality initiatives in the intensive care emphasizes on the points of ICU liberation. So the ICU liberation bundles actually include 6 components. I'm going to describe 3 components out of these, including ventilator liberation, rehabilitation and early mobilization, and managing sedation and withdrawal. So with ventilator liberation bundles in the ICU, we know as intensivists that prolonged mechanical ventilation can increase morbidity. So recently we had a release on the International Clinical Practice Guidelines for Pediatric Ventilator Liberation. That was an expert consensus that tried to look up the evidence and tried to come up with guidelines to enhance the liberation of the mechanical ventilation for PICU patients. So their first recommendation was that, using a protocolized screening for extubation readiness to facilitate extubation of patients who do not require mechanical ventilation. So there are many protocols in the literature for screening patients who are ready to be extubated. To be able to screen, to be able to check the readiness of extubation, there are certain prerequisites that those patients should have, including normal hemodynamic status, minimal ventilatory requirements, no requirements for further procedures. So we need to make sure that these indications are present while we screen them. So the screening for ventilator liberation or extubation readiness is done every 12 hours or every 24 hours, according to the policies of every institution. Once the patients are decided to be ready for liberation from the mechanical ventilator, he or she can change to CPAP pressure support, and those who passes the spontaneous breathing trial could be given an extubation trial. So spontaneous breathing trial was found to be a good predictor for extubation success in about 92% of patients. In in respiratory therapy-led pathway for extubation readiness, quality projects that utilize or use the bedside respiratory therapy for screening for extubation readiness found that the mean time for screening patients for readiness of extubation decreased from days to hours. With that, there was a demonstrated decrease in the length of stay in the ICU, as well as the duration of mechanical ventilation. So, reviewing the quality projects that looked at the impact of spontaneous breathing trial on mechanical ventilation duration, some of these trials have shown that mechanical ventilation was reduced in the group of patients who received spontaneous breathing trial. Some of the other trials showed no difference. And this is an example. So if this is a group of patients who was screened for extubation readiness versus the control. And the experimental group showed a lesser duration of mechanical ventilation compared to the control group. Now, the next point is early mobilization and rehabilitation. So a minority of PICU children are mobilized. This is very well known. And this is probably because those patients are intubated and sedated, and there are often issues or concerns about safety issues, about dislodgement of their devices and security of their lines. Multi-center trials showed that only about 10% of children received early mobilization, and that was conducted in one of the Canadian studies. Majority of the patients received interventions like chest physiotherapy and occupational therapy, which are non-mobility in nature. So the barriers to early mobilization in PICU include resource limitations. So limitations with staffing, like inadequate number of nursing staff or physiotherapists to move the patients, limited awareness of existing evidence that goes with early mobilization, lack of awareness of guidelines of how to mobilize patients, and very commonly fears about patient safety. Once mobilization is decided, it should be individualized according to the development age of the patient and according to the severity of their illness. Timing-wise, of when early mobilization should be conducted, most has agreed on initiation of early mobilization during the initial 48 hours to 72 hours from their PICU admissions, and that the mobilization could range from 10 minutes to 30 minutes every time, and it could be conducted once or twice per day. This slide shows a bundle of practices which was developed by Chung et al. And it basically includes screening patients for contraindications for early mobilization, and then assessing for precautions, and setting an activity goal, and then mobilize the patients with careful assessment of their vital signs and their stability. So for them, for this set of recommendation, the patients is going to be mobilized according to preset goals, and these goals are going to be reviewed and documented. The last point is management of delirium and withdrawal. Delirium is defined as a syndrome of acute brain dysfunction, which is characterized by inattention and awareness with possible secondary changes on cognition. It was found to be prevalent in up to 80% in the PICUs. There is a very good association between delirium and the length of ICU stay. So if you look at the graph here, this is the group of patients who has delirium, and this is the group of patients who has no delirium, and the group who has delirium had a longer length of stay in the intensive care. Benzodiazepines was strongly associated with development of delirium, and an increase in benzodiazepine dosage also was found to increase the risk of delirium. Most of us are aware of this guideline, which came from the Society of Critical Care Medicine a few months ago, and it includes the guidelines on prevention and management of pain and agitation, recognition of delirium, as well as withdrawal and their management. And this is an extensive summary of that guidelines. With the delirium, the recommendation for delirium treatment and monitoring is that we need to routinely screen the patients for delirium on admission and throughout their admission. The recommendation is to use validated tools like the confusion assessment monitoring and the coronal assessment for pediatric delirium according to the patient's age. And both of these tools were found to have high reliability. The guidelines also recommends preventative strategies for prevention of delirium, including a good sleep hygiene, maintaining sleep-awake cycle, family engagement, and involvement with direct patient's care. They also emphasize on the need to minimize benzodiazepine-based sedation when feasible, and try to use dexmedetomidine instead of benzodiazepines. The last point is about iatrogenic withdrawal syndrome. With withdrawal, the recommendation is to use validated screening assessment tools for withdrawal, including the Watts assessment score, and these were found to be validated in the assessment of withdrawal in ICU patients. It's recommended that we do a routine screening after a shorter duration of sedation and analgesia when higher opioids or benzodiazepines doses are being used. It's recommended that screening intervals should be conducted every 12 hours, and that if there is an opioid or benzodiazepine-related withdrawal, it should be treated with opioid and benzodiazepine replacement therapy to attenuate their symptoms. Although it's not very well described in the literature, alpha-2 agonist-related withdrawal should also be equivalently treated with IV and or enteral alpha-2 agonist replacement therapy to attenuate the symptoms. So in summary, we talked about children with prolonged PICU stay and the fact that they are increasing. We said that this category of patients are at risk of increasing morbidity and mortality, and they are also known to increase or to contribute to a higher resource utilization. In addition to having risk factors for long ICU stay in certain categories of patients, ICU admission itself can further increase the length of stay, and hence we need to implement quality projects like the ABCDEF bundles to improve the quality of care for prolonged stayers and to reduce the hospital length of stay. So this is the end of my presentation. Thank you.
Thank you very much, Khulud, for this extensive literature review. The floor is open for any question from the audience.